Hi guys, a lot of you had messaged me in response to my previous video saying that you found it difficult to solve MCQs either because the classes of DAMs and Bhatiyas are going on for 8-9 hours, following which you find it difficult to sit and actively solve MCQs. Some of you said that you have internship and it gets busy. A few of you also said that the Marrow explanations are too long and sometimes difficult to understand. So I thought we could have these small videos, small MCQ discussion videos. Hopefully I can post them every day, in which we discuss 5 to 10 important MCQs from previous years of NEET PG and also from high yield topics basically. So this is an exam where there's a lot of repetition, lot of previous year questions keep coming again and again. So going through them is is like mining a gold mine. So yeah, so I thought we could have these discussions. So let's get to solving. Yeah, so all the questions I've included today are from previous NEET PG papers, and all of them are high yield. So how this should work is I will read out the question. I'll give a 5-second pause. You will take longer to answer most probably, so you can pause the video and think about it. But make sure you do that, and you do pause the video and think about the answer, whether it's right or wrong, whether you know it or know it. Just pause and think about it, so that this doesn't become a passive process. Arrive at an answer, so you can also assess your line of thinking. It should be a very active, so you think of a certain reason why this could be the answer, and then it doesn't matter if it's right or wrong, but you'll know where your thinking altered. So pause the video, solve with me. Okay, so let's not waste any more time and start up. So first question, Budd-Chiari syndrome is based on Budd-Chiari syndrome. High yield topic, rare clinically, but high yield in NEET. So Budd-Chiari syndrome is due to thrombosis of which of the following? So A, infrarenal IVC, B, splenic vein, C, hepatic vein, and D, renal portion of IVC. Okay. Yeah. So let's get to the answer. So the answer is C, hepatic vein. Okay, so for all of you that selected hepatic vein, good work. So yeah, let's get to the discussion. A few important points about Budd-Chiari syndrome that you should know for the exam. So firstly, and most importantly, Budd-Chiari syndrome is an hepatic venous outflow obstruction. Hepatic venous outflow obstruction. So it is the hepatic vein that's involved. So there's a lot of confusion. Many people think it's IVC. Many people even think it's a splenic vein or superior mesenteric vein. But no, Budd-Chiari is very specific to hepatic venous outflow obstruction. So it's hepatic vein that's involved. So there are pathologically, we can say there are two types of Budd-Chiari syndrome. First is the primary Budd-Chiari syndrome, and the other one, the less common one, the secondary Budd-Chiari syndrome. So primary Budd-Chiari syndrome is nothing but there is an intramural thrombus. So there is a thrombus forming within the vessel, and that blocks the venous outflow. So secondly, or the secondary Budd-Chiari syndrome is due to some secondary cause outside the vessel. So it's some tumor or mass that grows around like this, and that obstructs the vessel. So when the mass pushes on the vessel and obstructs it, it becomes a secondary Budd-Chiari syndrome. So it's nothing but an obstructive cause of Budd-Chiari syndrome. So how does the patient with Budd-Chiari syndrome present? What are the investigations we want to send? And in brief, how do we manage it? So firstly, a patient with Budd-Chiari syndrome presents with, okay, before I say that, it's an acute or subacute in onset most of the times, which means it develops in weeks to months. So subacute onset is the most common type. So coming to the clinical features, the patient presents with abdominal distension, that is ascites, and upper abdominal pain. So these are the most common presentations: abdominal distension, ascites, and upper abdominal pain. So on examination, you can find hepatomegaly because the venous outflow is obstructed and there's congestion, so the liver automatically becomes big. So that's a clinical presentation. So patient has come with these complaints. What do you do next? So firstly, what is the investigation of choice? So this is really important. Investigation of choice is nothing but the usual USG abdomen with the Doppler, just to look at the outflow. So USG abdomen will show hepatomegaly. It will show, most importantly, reduced venous outflow. Hepatic venous outflow will be reduced or nil. And third thing is there will be a lot of collaterals formed because of the outflow obstruction. So that is the investigation of choice. Now, the gold standard investigation. So gold standard is what is definitive. So the definitive investigation is the hepatic venography. Sorry for handwriting. So yeah, hepatic venography is the gold standard, and that will definitely give you that's the definitive investigation basically. So this is in brief about the clinical features investigation. Finally, the management. Always, like most diseases, first we try the medical line of management, then we go for the surgical line of management. So firstly, the medical line of management, the first and most important is anticoagulants are given. Heparin and warfarin are usually given for Budd-Chiari syndrome, and if this doesn't work, we start going to the next line. So the second line includes angioplasty and stenting, similar to what's done in the heart. The third line are shunting procedures, either surgical shunting or TIPS. So you might have already read about TRIPS, right? TIPS, it's a transjugular intrahepatic portosystemic shunting. The procedure we can discuss later. This is just a brief answer which I'm giving. So TIPS or surgical shunting can be done, and the last line resort, or the fourth, as in all liver conditions, is the liver transplantation. So that is Budd-Chiari syndrome in brief. Okay, so the next question, we'll go to question number 2. Right, so which is the most common cancer in Indian women? Which is the most common cancer in Indian women? A, CA breast, B, CA cervix, C, buccal CA, and D, CA ovary. Okay, so there's a lot of controversy with regard to this question. A lot of people think it's this and that. Now, I've also included this picture, which can itself come as a question, which can give you a clue. So, yeah. So let's get to the answer. So the answer is A, CA breast. Okay, so CA breast is the most common malignancy in Indian women. Let me also mention it is the most common malignancy in women abroad, in Indian women, and also in women in general. So world over, all when it comes to the most commons, and most commons are something that the NEET examiners like to keep asking. So when it comes to the world in general, in women, breast cancer is unanimously the most common. So other than that, let's also just have a small word about the most common cancers in men, right? So in India and in the world, it differs. So in India, the most common is buccal CA, that is CA oral cavity and lip, and this is in men. Okay, men. And in the world, the most common cancer among men is lung cancer, right? Overall in the world, most common is lung cancer. So in Indian women, breast cancer. In all over the world, breast cancer for females, so breast in females. And in men, it is lung world over, but in India, it's buccal CA, and we all know why, right? So just a small statistic, the incidence of breast malignancy in India is 92 per 100,000, whereas the controversy was, a lot of people think it's CA cervix because we believe that it's more common in lower economic strata, and where India stands. So that's why there is a belief that it's CA cervix, but that is wrong. CA cervix is around 72 per 100,000 in India. So let's go to the next one. Yeah, so the third question. So this is not a very high yield topic, but I've included this question to show you different ways of answering something and not to get flustered even if you haven't heard of it, right? So citron bodies are formed by which bacteria? Citron bodies are formed by which bacteria? A, Staphylococcus species, B, Klebsiella species, C, Yersinia species, and D, Clostridium species. So let's give it a few seconds. You can pause. Yeah. So again, this is a very fact-based question, difficult to answer. We might not have even heard of citron bodies, but there is an image with this question, and that can help you answer. So what you can see in this image are gram-positive rods, right? Gram-positive rods. So let's look at the options. So A is staphylococcal species. So staphylococcal is gram-positive cocci, right? So it's not a rod. So that's ruled out, right? Next, we go for Klebsiella species. So let's, if you remember bacteriology well, Klebsiella is a gram-negative rod, right? It is gram-negative. So we know these are gram-positive. See, they're all purple. So this is ruled out. So Yersinia, again, comes with Klebsiella. It is also a gram-negative rod. So we ruled out these three. So probably the answer should be Clostridium species. And yes, that is the answer. So Clostridium species, particularly Clostridium septicum, is associated with citron body formation. So Clostridium septicum, citron body formation. And where do you see Clostridium septicum? You see it in gas gangrene. So few points about Clostridium septicum. Again, people love to ask about Clostridia. So first of all, the Clostridium groups are gram positive rods, okay, and they are anaerobes. So remember, all Clostridium gram positive rods that are anaerobes, mostly spore forming, okay, and four of them are really important. Firstly, Clostridium tetani for tetanus. Second, Clostridium welchii for gas gangrene, right? Third, Clostridium septicum, again associated with gas gangrene. And lastly, Clostridium difficile, which is antibiotic associated diarrhea, right? So that was citron bodies, Clostridium. Next question. Most common clinical feature of Graves' ophthalmopathy. Again, Graves' ophthalmopathy, hyperthyroidism, hypothyroidism, very, very important for NEET. Definitely there'll be at least two, that means 8 marks, 2 questions of thyroid in NEET. So Graves' ophthalmopathy, most common. Again, something that the NEET examiners love, is a very fact-based thing, most common. So here you have a picture of Graves' ophthalmopathy. So get thinking: A, exophthalmos; B, Dalrympe sign; C, von Graefe sign; and D, Mobius sign. Okay, so the answer is B, Dalrympe sign. Very fact-based question, not easy to remember, but we have to remember. So D, Dalrympe sign, which is also called lid retraction. Okay, so Dalrympe, lid retraction. Let's talk about the other few. So what is exophthalmos? It is nothing but the anterior bulging of the eyeball outside the orbit. Anterior bulging of eyeball outside the orbit. Okay, and von Graefe sign is nothing but your lid lag. Lid lag is called Dalrympe sign. That is when you look downwards, the upper lid takes some time to come down. So that is a lag. And lastly, Mobius sign. And Mobius sign is the absence of convergence of the eyeball. So it's the absence of convergence of the eyeball. So a few things about Dalrympe sign, because the question was based on that. So how do you know if it's positive? You can see a bit of sclera over the iris. So you can see this small patch of sclera between the lid and the iris. So that is seen because of the lid retraction. And why does lid retraction happen in this case? It's because of the overaction of the Muller's muscle. So when in case of Graves' ophthalmopathy, there is an overaction of the Muller's muscles, and that's why you see it here. Also, a small statistic: 90% of cases of Graves' ophthalmopathy, right? 90% come with the Dalrympe sign. So 90% of cases have Dalrympe sign. So it's that important. So remember, Dalrympe, most common. Other few, I've told you what they are. Again, this is a high yield topic, so let's quickly go through them. We're running out of time. So Rosenbach sign is tremors on closing the eyelid. You can see that. Stellwag sign is staring look. So S for S. Stellwag, staring. Stellwag, staring. And staring obviously means less blinking. So if I keep doing this, I'm not blinking enough. So Stellwag for staring or less blinking. Dalrympe sign, a rim of sclera is seen between the cornea and the upper lid. Rim of sclera between cornea and upper lid, I showed you in the previous photo. Dalrympe sign, most common, most important. Von Graefe sign is lid lag, I already told about it. Geoffroy sign, there's lack of frowning of the forehead when the patient looks up. So when you look up, usually you have a lot of frowning. For them, it won't be there. Lastly, Mobius sign is a lack of convergence. So convergence is lost, right? So the next question is and the last question for today, which of the following statements is true about keloid scar? So keloid, another high yield topic, but I also added this question because which of the following is true is a common theme. So which is false, which is true, all are common themes in NEET. So practicing them helps you answer. So let's get to it. 5 seconds. So, sorry, I didn't read the options. A, extent does not cross the wound margin. B, wide excision prevents recurrence. C, histopathology shows reduced collagen and vascularity. And D, it is formed due to increased action of growth factors. So which is true? So just remember true and look for what looks true. You can use the picture to help you. Yeah. So the answer, very obvious, is D. It is formed due to increased action of growth factors. So we know that keloid is a scar or it's a type of hypertrophic scar in which the scar tissue or the wound tissue extends the beyond of the initial injury or initial site. So it obviously has to be due to increased growth. So let's look at the other options and try to rule them out also. Does not extend the wound margin. So it is a larger than normal scar. So it definitely does extend the wound margin. So that's ruled out. Next is wide excision prevents its recurrence. So this is something which has to be remembered about keloid. Recurrence is really high. So this is ruled out. Post wide excision, you have good recurrence. just wide excision if you do. So lastly, HP shows reduced collagen vascularity. That's wrong. It's a larger or a hypertrophic scenario. So there is increased collagen and increased vascularity. So you can see it's a reddish also due to the increased vascularity. So what, in brief, let's review keloid. It's a defective scar formation. The boundary extends the boundary of the wound. There are increased growth factors. That is what leads to formation of keloid. There is a hereditary link also. And if you look at the histopathology of it, there is increased, and this is a very common NEET question, which type of collagen is increased. So increased type 3 collagen in keloid, increased type 3 collagen in keloid. It is hypervascular with a lot of fibroblast tissues, and it is most commonly seen in a triangle between the shoulder blades and the xiphisternum. So in this triangle is the most common site of keloid formation between the shoulder blades and the xiphisternum. Right. Now lastly, in brief, about the management of keloid. So firstly, intralesional triamcinolone, it's a steroid, has been used and found to be beneficial. So you inject triamcinolone into the steroid. Second thing is excision followed by steroids has worked. Wide local excision followed by steroids has worked better than just wide local excision, which has high recurrence, as we discussed. Third thing is excision followed by radiation, again because of high local excision. And of late, new laser treatments have been tried which are reducing the vascularity, thus reducing the size and redness to some extent. So that's the end of the discussion for today. 5 important topics have been covered and few methods of solving. Lastly, I just wanted to say this platform, Unacademy, it's an interesting platform. They've just started their NEET PG session, and they got in touch with me and asked me if I could do a few sessions for them. So I will be doing a few sessions for them. I did agree, and I will be doing a few sessions for them in the coming few days. I think from tomorrow 7 p.m. would be the first session if everything goes as planned, on again tips and tricks for cracking NEET PG. So thank you to Unacademy, and just want to let you guys know, and thank you for all following and making this possible. So yeah, bye.